Ladies and gentlemen, I'm very delighted to speak to you today about the pathophysiology, the diagnosis, and the therapy of spontaneous preterm birth. And speaking about the therapy, I use evidence-based medicine, and the main interventions are progesterone, cyclage, and Pessarrie. Well, up to now, most guidelines in many countries have only considered tertiary prevention. That means that we are mostly dealing how to make progress when spontaneous birth is immediately threatening or has already happened, and neonatology has improved the outcome of spontaneous preterm birth. There are only very few studies dealing with primary prevention of preterm birth. And one of the great pioneers was Professor Papiernik, who unfortunately died some years ago, but he succeeded in reducing preterm birth in a whole region around Paris just by reducing physical stress and improving maternal care. But this study has not yet improved or has not yet reproduced. Another primary prevention would be the treatment with omega fatty acids, but also these studies are scarce and have to be reproduced before we can really recommend it. So what I'm talking to you now is mainly measures of secondary prevention. That means the prevention of preterm birth when we have already first signs of preterm birth threatening to occur. And I would like to summarize the state of the art for clinicians nowadays, and thus to give an inspiration to healthcare politicians and maybe researchers. Well, the first topic is the epidemiology, and I now talk to you from Marburg. University is called Philipps University, and in our region of around 8 million inhabitants in this country, we have not succeeded to reduce the rate of preterm birth, but we have succeeded, what I told you before, to organize that women with threatening preterm birth deliver in special perinatal centers. We have to consider that every 30 seconds a baby can die from preterm birth worldwide. And this has not been reduced during the last years and mainly increased. The countries with the highest number of preterm births and births in general is of course India, with more than 3.5 million preterm births a year, and China with more than 1 million preterm births a year. But the rate of all deliveries changes also between these countries. For instance, in Germany it's about 9% of all deliveries, whereas in Africa it can be double as much, up to 18%, and in the United States it's 12%. The rate of death, of course, depends highly on the quality of neonatal care. Well, today all of our efforts are from the diagnostic side, but also from the therapeutical side, concentrated on the cervical length and cervical tissue. And this has not always been like that, because in early anatomical pictures the cervix was not even designed, and only in 1865 there was the first remark in the medical literature that a soft cervix could be the reason of preterm birth. But only 100 years later there was the first systematic study on short cervical length as a risk factor for prematurity, But it was also shown 30 years later that clinical investigation, digital examination, did not reduce the rate of spontaneous preterm birth. And when we look at anatomic or histologic examinations of the cervix, the papers of Danford are very interesting, showing that the collagen tissue resolves at term or before birth occurs, also before preterm birth, and that the tissue of the cervix differs because in the upper part there is more muscular tissue, about 30%, but at the lower part there's only 6% muscular tissue, but there is then an increasing number of collagen tissues. And while the cervix is shortening and dilating, the effacement is seen, and the fibromusculus junction goes up to the lower uterine segment. At least it appears like that. We know from the early work of Romero that spontaneous preterm birth is a syndrome, and it's based on 3 main groups. One are myometrial contractions caused by stress, hypoxia, or other factors. One is the decidual membrane activation, mainly caused by infections and inflammation. And then there is the cervical ripening, and all of these factors are intercorrelated. And what you see from the histological pictures on the bottom is that the collagen bundles dissolve when there is cervical ripening, and there are quite some interesting scientific papers showing that also the matrix of the collagen tissue changes. There are more cells known from inflammation which invade into the cervical tissue, and there is a change of proteoaminoglycans and collagen metabolism. And these changes I've described can all be seen indirectly by ultrasound, mainly by transvaginal ultrasound. And these are the standard measurements. We measure from the external os to the internal os as a line. And in cervical ripening, also in preterm cervical ripening, the opening starts from inside, from the internal os of the cervix, and this can be in a form of a V shape or a U shape, whereby the membranes protrude into the cervix. But even when the internal cervical length is 0, there can be still some outer cervical tissue. So this is important for our therapeutical concepts. Well, transvaginal sonography was first described by Anderson in its value to predict spontaneous preterm birth, followed by the classical paper of Imes in the New England Medical Journal in 1996. And he also showed that the shorter the cervix, the higher the probability that the woman will deliver preterm. And meanwhile, in this year, the group of Nicolaides has even shown that the early measurements in the first trimester even correlate with the gestational age at birth. So the shorter the cervix, and together with other high-risk factors, the higher is the risk that the woman will deliver spontaneously preterm, although there are no studies up to now starting in the first trimester. So the positive predictive value was 55% with a false positive rate of 10%. Very interesting are the papers of Honest, and they are important for our clinical behavior. Honest could publish in the White Journal that there is no specific cut-off value, and that we know from SEP scores and centiles, and that the earlier you see the shortening of the cervix, the more predictable it is for later spontaneous preterm birth. On this slide you see that in singleton pregnancies, a cervical length of 20 millimeters measured before 20 weeks has a likelihood ratio of 15, whereas the same cutoff level after 24 weeks has only a likelihood ratio of 5.8 to predict spontaneous preterm birth before 34 weeks. But here on the second slide you see the same kind of analysis for twin pregnancies. And you see that if you measure in a twin pregnancy, cervical length below 20 millimeters before 20 weeks, the likelihood ratio is even tremendously higher, namely 60. And when you measure 20 millimeters after 24 weeks, the likelihood ratio that this mother of a twin pregnancy will deliver spontaneously preterm is only 3.4. And this slide really suggests, though it was not yet sufficiently considered, that we have to start screening in twin pregnancies as early as possible, at least before 20 weeks, and possibly also to treat them before 20 weeks. Well, here you see a videotape of a pregnant mother of twins. You see the hand of the first baby, and now at this moment we ask her to stand up. And you see that during standing, the internal os opens and the cervical length in the endocervical internal length decreases to 0, and there is an increased amount of funneling. And we have published this already in 1997. And sometimes we let the woman stay up, as you see on these pictures, and let her introduce her own the transducer, so that we do not hurt her. And you see here that also in this mother the cervix dilates from the internal os, and there's funneling during standing, whereas when she lies down there is a so-called rebound phenomenon, and this has been already scientifically described in the Netherlands by introducing ultrasound crystals during birth, and in the late so-called latent phase you saw the same phenomenon during contractions. That means that during a contraction there was internal funneling, but in between two contractions, when there was a pause, the cervix restored, whereas in the acceleration phase there is no restoration any longer. We could show in a later more sophisticated analysis that standing up improved our prediction of preterm birth, both in singleton pregnancies, here pink, and in twin pregnancies. And you see that the likelihood ratios is highest when we consider funneling width, FV, or cervical length in the standing or upright position, up, compared to the recumbent position. But of course also the values in the recumbent position have a predictive value. Still, we have to consider that even during lying, the cervical length is not always a stable factor, because you can have, even with subclinical contractions, spontaneous funneling, and thus a reduction of the endocervical length, and this means also that in risk patients we have to look a bit longer and don't have to do only a short snapshot to the cervix. Of course, there are different markers, such as the membrane separation, which also independently predict preterm birth. Here you see a separation within the funneling of amnion and chorion, and this is mostly combined with positive fibronectin. From fibronectin, it is known that a negative fibronectin really excludes in nearly 95% that the patient might deliver within the following 2 weeks. So we have to avoid then to give unnecessary corticosteroids or tocolysis, or even to hospitalize them. In positive fibronectin woman with symptoms of spontaneous preterm birth, the predictability is less reliable, and the ACOG, the American Board of Obstetrics and Gynecology, does not yet recommend routine fibronectin testing. However, in a big prospective trial in Holland, which is not yet published, they could again prove that if you perform fibronectin tests, you can at least reduce the number of unnecessary transfers and unnecessary treatment, and thus to reduce the cost of a system. Another factor, independent factor of the cervical length for preterm birth, is sludge. Sludge was for the first time scientifically described by the group of Romero, and it is characterized by white spots, mostly found in the neighborhood of the internal os, and there are different grades of so-called sludge, and the group of Romero has done amniocentesis in these patients and could prove that in some of them there were bacteria surrounded by a microfilm, so probably not really treatable with antibiotics. But in some patients it might only be leukocytes, and thus the sludge might also disappear. Still, we know that the earlier we have cervical shortening, there is an increased role of inflammation and infection. And this was also described by the group of Romero already 20 years or 25 years ago. And of course, when there is an ascending bacteria between the membranes and the decidua, the grade 2, there is a higher risk as if the infection is only in the cervix. And where we are extremely afraid of is that these bacteria go into the amniotic cavity, which is called MEAC, and also to the fetus. However, we have to know that MEAC is a physiological process at all deliveries, and that you find microbial invasion of the amniotic cavity in 75% at the onset of delivery in all pregnant women. So only when it stays for a longer time and very early, this can be harmful. And in patients at early gestation with a cervical length below 15 millimeters, it has been proven in singletons that the rate of MEAC is 28%, whereas it's much lower when there is a longer cervix. We also have to consider that bacteria are different, and that also the response of the maternal body to bacteria in the amniotic cavity is different. And for instance, here it was shown that in microorganisms such as mycoplasmas, the response is much more increased, and thus also the danger of spontaneous preterm birth. We have to consider that a lot of treatment we have done over years and which are still performed in a routine way in Germany and in many Western countries can do more harm than good. And here, this is a picture taken from the group of Romero again, and showing that if we give atosiban, tocolysis, before 28 weeks, it has no real effect on the outcome of pregnancy. And even worse, if we go if it was given before 26 weeks, the rate of perinatal death was even increased in the group where atosiban was given, and probably this is due to MAIAC, because these fetuses had already infection, and then it's better to deliver them and not to hold them in utero. And it has also really been published now, and which is really very, very important, that antibiotics in patients with intact membranes can do harm. And it has been proven by evidence-based medicine that antibiotics in patients with intact membranes fail to prolong pregnancy. They are combined with an increased rate of infection of the neonates on the neonatal intensive care unit. And even worse, after 7 years, they are combined with an increased rate of cerebral palsy. And the number of needed to harm was 64 for erythromycin, and it was 79 for co-amoxicillin. But nevertheless, we have to tell this our patients, and we don't have to treat any colonization of the cervix. We do more harm than good. There is a paper showing that indomethacin in early gestation might reduce preterm birth, but after 24 weeks this has never been shown, and we know we have to be very cautious with indomethacin.